Hi, everyone. Thank you for joining. As I mentioned earlier, my name is Jackie Seisman. I'm the Assistant Director of Baby's First Test, and today we're talking about health equity and newborn screening. Just a few webinar logistics before we get started. This webinar is being recorded, and a link will be available on the Baby's First Test YouTube channel within 48 hours. If you have any questions throughout the presentation or at the end, please use the chat box. We'll be collecting them, and then we'll make sure that we have a few minutes at the end of the presentation to go over those. Again, questions will be addressed at the end of the webinar, and if you need any IT or technical assistance, please use the chat box to communicate. Just to go through what we're going to be discussing today, we'll give a quick introduction to Baby's First Test. Then we'll be giving you a 101 on health equity. That will be followed by health equity and newborn screening, and what do we mean by that? And then we'll be joined by the Iowa Newborn Screening Program staff to discuss their experiences around health equity and newborn screening. But first, we'll start with a quick introduction of who we are. We are the Newborn Screening Clearinghouse, and we are created based on the Newborn Screening Saves Lives Act of 2008 and reauthorized in 2014. And these were based off consumer-focused newborn screening projects. And essentially, we help increase newborn screening awareness, training, and education through engagement. And engagement is a key piece of who we are. But we are that one-stop shop for newborn screening information and education. Baby's First Test houses the Newborn Screening Clearinghouse, and as a clearinghouse, we help inform and support millions of families and healthcare professionals throughout the newborn screening experience. BabiesFirstTest.org is our primary platform to increase engagement and education and awareness. And we have multiple ways that you can learn, connect, and share about newborn screening. And we do this through creating information on what to expect, living with a condition. We include family experiences, both on the site as well as on social media. We have information on all state programs, including what they screen for, as well as there's policies and procedures. We have information on all 78 newborn screening conditions. We also include educational resources that can be found in our Educational Resource Center, where you can download or order newborn screening resources. We have our interactive national map, and we also have our public squares where you can have informative, interesting, and engage with newborn screening conversations around the country. And finally, we're also very involved in social media. So since 2011, since Baby's First Test launch, we've had over 2.5 million visitors and 5 million hits on the site. But we wanted to have a better understanding of who was actually coming on the site. So we conducted a user survey in 2015 through 2016, and we found that approximately half of the members that are coming to the site or users are family members of newborns, and the other half are healthcare professionals. But we also have a small slice, about 7%, that are advocates. Also, through this user survey, we learned that 65% of users reported that they learned something they didn't know before. 85% reported that they were able to find information they were seeking about newborn screening, and they found that it was easy to find. And 90% of their questions were able to be answered by the site. In addition to our English platform, we also have Spanish BabiesFirstTest.org. We also have an ongoing survey right now on the site, and we've learned that about 60% of those that are visiting to the Spanish site are family members. Also, through our analytics, we've learned that 60% or more are visiting and looking for information about newborn screening online through their mobile phone. So we thought it was really important to make sure there was an app for that. So we do have a mobile app, so it is available on the iTunes stores as well as Google Play. You're able to search for state and condition information. You're also able to save your searches, and of course, it's for free. Finally, that's kind of an overview of kind of our web platforms, but we also do so much more than that. We do have our Consumer Task Force program. We also have our Challenge Awards program, but we also help state and other organizations with their educational efforts. So some of the things that we do, we review educational materials, We can create and co-brand educational materials. So if you see something on babiesfirsttest.org that you would like to either co-brand with us, or you find a new educational material is needed, we're happy to help work with you to create that educational material. We're also able to help you with any technical assistance around education. So if you have questions about how to reach families in the prenatal period, or about educational resources, or working with health professionals, we're able to talk that through with you. So if you're interested, you can always contact us after. And for many state programs, we've also given presentations to advisory committees. So those are just a broad overview of kind of what Babies First Test is, our activities, as well as what we're able to do for state and public health professionals. So now, I'm going to hand it off to Annie Evans, who is our program coordinator at Babies First Test, who will be giving an overview on health equity. But before we get started on that, I just want to get a better idea of who's actually on the line. So I just launched a quick poll that's really saying, are you interested in newborn screening health equity as a? And if you can select one option, and then we'll continue with the webinar in 1 minute. Great. So based on the poll, we have a lot of state employees, some public health, no families as of yet. We have some health professionals and advocates. So it's a great mix. And I think that shows that there's a lot of perspectives on the line. So we're interested at the end of this to really hear about your perspectives about health equity, and particularly around newborn screening. So with that said, I'm going to hand it off to Annie Evans to give you an overview on what is health equity.
Hi, everybody. As Jackie said, I'm Annie. I'm the program coordinator for Babies First Test, and I'm going to switch gears a little bit here, and we're going to get into some of the main content for this presentation, which is health equity. So today we're going to discuss health equity in the context of newborn screening, and we're going to include specific examples of how health equity can impact newborn screening at several different points along the process. Our speakers from Iowa will discuss some of their experiences dealing with health equity issues in the field as well. But before we dive too deep, we want to take a moment and define what exactly health equity is, because sometimes the nuances between health equity, health disparities, and health inequalities can be pretty confusing. So let's start with health equity itself. Health equity is the achievement of the highest level of health possible for all people. For someone without any serious health conditions, achieving the highest level of health may be eating well, exercising regularly, or getting regular checkups and screenings. For someone with a physical disability, this might mean all of those things, but also attending PT and having access to an assisted device like a wheelchair or braces or a prosthetic. For someone with a metabolic condition, as most of us probably know, this may mean sticking to a special diet and taking formula every day. And for each person, the highest level of health is different, and the needs to gain that level of health are different. So these are some health inequalities. So now, most of you have probably already seen this image or something similar before, but you probably know what I'm about to say, but stick with me because it's really important to make this distinction when you're discussing health equity. So basically, when we look at health inequalities, we have to recognize that there are some health inequalities that are inherent. Some people are born with health differences, and it's important to use a health equity lens to promote programs that provide assistance for those inequalities so everyone can achieve health equity. So now let's shift the discussion to health disparities. Unlike health inequalities, health disparities are not inherent. Health disparities are caused by social, economical, racial, environmental, or cultural factors. Health disparities can be introduced at any point in a person's life course, or even in conception or preconception, or as studies have shown. To avoid health disparities, it's important that we, as health and public health professionals, prioritize creating equitable programs. So you might be asking, how do I create an equitable program? And unfortunately, there's no simple answer to that question. The contextual nature of health equality or health equity makes every issue unique. And that being said, there are some strategies that you can use to employ a health equity perspective in your programs. First of all, you need to have an understanding of how cultural context is influencing the health issue you're interested in. And I don't mean culture just in terms of race or ethnicity. Depending on your audience, this could mean understanding the culture surrounding different disease groups. You have to understand the cultural perspective of the community as well as the influence of your own culture on how you perceive an issue. It's important to consider both sides of this because your perspective may not be aligned with the community you're working with, and that can cause issues. If any of you have ever read The Spirit Catches You When You Fall Down by Anne Fadiman, you might understand that parents in that book had a different idea of what health looked like for their daughter with epilepsy than the medical team treating her. They saw her condition as a valuable connection to the spirits, whereas her medical team saw it as exclusively harmful. And this clash of cultures really made things difficult for the parents, the medical team, and the child. It's also important to understand the historical influence on the community and the issue you're working with. Past interactions with health professionals or programs can be a powerful influence on cultural perspective. So in cases where communities have had negative interactions with health professionals or programs in the past, they may be reluctant to engage in the future. One famous example of this is the story of Henrietta Lacks and the researchers at Johns Hopkins who cultured her cells. And the emotional toll that the use of Henrietta's cells without the permission or knowledge of the family took on this Turner Station community is one that will be felt for a very long time. On top of years of Johns Hopkins' unethical experimentation on African American communities in Baltimore, it's easy to understand that the people living there might be very wary of health professionals and programs. So for communities who've experienced health disparities, it's really essential to be transparent and build trust to create successful health equity programs. Without these elements, communities may not be willing to utilize or engage with programs because of the negativity created by cultural insensitivity or other historical influences from the past. Building trust with the community can help to overcome these issues, but it's probably going to take time. Building partnerships and community leaderships can also help to encourage trust and make sure the community needs and wants are at the center of health programs. Creating relationships with partners who are gatekeepers to the community can help you find ways to build trust and design programs that are needed and utilized. So now we're going to get into some of the specifics of health equity in the context of newborn screening. But before we do, we want to acknowledge that newborn screening is known to be one of the most equitable programs out there. But that doesn't mean that there isn't room for improvement and exploration. So we'll examine this by discussing where health disparities can be introduced in the newborn screening process. So we'll start by discussing where health disparities can enter before newborn screening. As we know, newborn screening is universal in the U.S. All babies have the opportunity to be screened, but not all parents have the opportunity to have prenatal education about newborn screening. This means that parents who don't have access to prenatal care and education miss out on an opportunity to learn about newborn screening. And this lack of awareness means that they may not understand the results, they may misunderstand the meaning of the term screen, or they may be less prepared to respond should the screen return an out-of-range result. And as we know, any delay in the critical time period for follow-up testing and response can be deadly or potentially create poor health outcomes. So the same socioeconomic factors that influence access to prenatal health care will govern access to prenatal education on newborn screening. So it's really important to look at this issue from a health equity perspective. So after newborn screening, there are also opportunities for disparities to enter. Follow-up testing is one way, as it's not always accessible to families who need it. This can be due to a number of factors, such as the ability to pay or even geography. As I'm sure many state newborn screening professionals listening in will understand, sometimes geographic factors can influence access to follow-up screening. Some states are huge, and there are not always metabolic clinics within easy driving distance from families that need them. And what if a family doesn't have a car? Gaining access to a metabolic clinic can be really complicated for families of lower socioeconomic status with limited transportation options. And we'll talk a little bit more about this later as well. Looking beyond follow-up screening, health disparities can also enter at any point during the long-term follow-up. Health equity is a really systemic problem in nature. Kids and adults with newborn screening conditions have to navigate the complicated U.S. healthcare system regularly, and their care can be easily influenced by any of the health equity factors that play a role in the healthcare system, such as insurance coverage and ability to pay for care, geographic access to care, like we've already talked about, or provider bias, which I'm going to touch on in the next set of slides. And those are just to name a few. So another important thing to acknowledge in this discussion is that each state has its own newborn screening panel, meaning each state screens for a different set of conditions. So looking at this map from the Baby's First Test national maps, we see that there's even a lot of variation between which rust conditions are screened from state to state. Only Minnesota and Pennsylvania screen for all of them. And while there are many valid legislative reasons for this, we have to acknowledge that it does create a differential, especially in states where people may have limited ability to pay for additional screening or don't have access to medical care after birth. So now, as promised, I'm going to shift to a discussion on specific examples of how one newborn screening condition can be impacted by health equity through provider lens. So looking at literature and a lot of anecdotal information, the presence of provider bias towards sickle cell patients is very well documented. This provider bias limits the capacity of sickle cell patients to achieve the highest level of health possible, and so creates health disparities. So providers tend to perceive sickle cell patients as drug seekers, and this is caused by several factors. Sickle cell patients, often experiencing painful health crises, do not tend to exhibit the same pain behaviors that other patients would. And though they don't outwardly show it, they're still in a lot of pain that requires treatment, sometimes with opioids. And some sickle cell patients develop opioid tolerance from repeated exposure, meaning they may need higher doses of those drugs. And additionally, sickle cell is more prevalent in African American populations, and healthcare providers may have an implicit or explicit racial bias that leads them to perceive a drug-seeking behavior. So while this provider bias towards sickle cell patients has been very well documented through research, it can be hard for providers to acknowledge it within themselves. It's hard for anyone to recognize how internal biases may be influencing our actions, but it's really crucial. To help alleviate this, health equity programs geared towards training providers to recognize bias when it happens and how to avoid it can help overcome this issue. So with this in mind, I'd like to look at this quote from Levels of Racism, a Theoretic Framework and a Gardener's Tale by Kamara Jones, which some of you may be familiar with already. Provider bias in sickle cell is just one example of how institutionalized racism contributes to health disparities and why health equity in newborn screening can be improved. If you haven't read this publication, I would really, really recommend it. So to wrap up this introduction of health equity, I'm going to leave you with a few resources that you can use. So both the Minnesota Department of Health and the National Institute on Minority Health and Health Disparities have good resource libraries that you can search and reference for health equity information. You can also use healthequityguide.org for strategies shared by different health departments. If you're looking for something that's more related to stories or discussions, you could check APHA's Better Through Health Equity, Case Studies Reframing Public Health Work, or the Agency for Healthcare Research and Quality, Taking Action to Achieve Health Equity, Implications of the Affordable Care Act for Communities of Color. That's definitely a useful resource. And finally, you can look at the National Institute for Children's Health Quality and their document, Opportunities to Improve Health Equity for Mothers, Babies, and Children. So just before I turn it over to our speakers from Iowa, I'd like to acknowledge my sources. And if any of you are interested in looking at these further, please let me know. I'll be happy to send them to you. So I'd like to introduce our genetic counselors from the Iowa Newborn Screening Program, Jaclyn Kotlarek and Marcy.
Hi, my name is Jaclyn Kotlarek. I'm a genetic counselor that works with the Iowa Newborn Screening Program. You can go on over to the next slide. Yeah. So thank you, Annie. We would first like to thank you for inviting us to share some of our stories on this webinar today. First, we wanted to introduce you a little bit to Iowa and the barriers that we see with providing equitable services for newborn screening. We agree that we experience similar types of barriers in providing equity just in our newborn screening program in general. Just to highlight a few, as on this slide here, we have a wide range of population in Iowa. The most kind of important barrier, the most significant barrier that we come across is this geographical one. I know only a portion of the screened conditions on the newborn screen are metabolic. However, we only have a single metabolic genetics clinic in the state. As you can represented by that star there on the state of Iowa, it's not necessarily centrally located. So when we have families coming from the far western side of the state, it can be difficult to get there even halfway through the state as well. And we also have smaller communities of kind of specialty populations in Iowa as well, and also a large rural population. Then we wanted to go into a couple examples for you guys that just highlight some of these barriers and some of the strategies we have used to kind of help mitigate or kind of overcome these barriers as well. So we can go on to the next slide. So our first example is a metabolic newborn screen. So just to kind of paint the situation a little bit, this was a newborn screen that was positive for VLCAD, or very long chain acyl-CoA dehydrogenase deficiency. So per usual, as I normally do, the primary care provider was notified and the family came back in for second tier testing, all in a timely manner. And then also a referral was made to a metabolic genetics here at the University of Iowa. At that time, not all of the second tier testing was completed. As any of you know, if you're working with babies specifically, it's hard to get them to collect a urine sample on a baby. It seems to be unpredictable. So they were allowed to take it home and they were supposed to drop off the sample once it was collected, which I believe failed to happen. In our normal way, the genetic counselor, which was me in this instance, called to review the newborn screening results and schedule the baby in for diagnostic testing with our metabolic geneticist. I specifically had a difficult time understanding the father, so they did come from, or English wasn't their primary language. They did decline an interpreter and did insist on using English to communicate, which we did eventually get through all of the important information. The family was receptive to coming in and very understandable of the what it was a screen and that it was not diagnostic at this time and we needed to do additional testing to know for sure. But they couldn't come on a very short notice, and father was very concerned that he could not miss work in fear of losing his job. Typically, that's not a response that we get when we're talking about newborn screening. Usually we get someone who is quite anxious and they want to get in as soon as possible to kind of move along with the process. However, we do think about a couple things when we hear someone saying that they're afraid of losing their job, especially when we're thinking about the possibility of someone being undocumented and where not coming to work would be used against you and you're not qualified for that FMLA kind of excuse for not being there and threatening to lose your job for that. That was unconfirmed, but something that we do think about. So we were able to schedule an appointment with the family when they could be there. So we just kind of laid it out what time they were available to come. That it was about 2 weeks out, and they agreed to continue on with the frequent feeding and the management that we put on our VLCAD, or all of our fatty acid oxidation screens. Then going on with the scheduling, oh, sorry, not to example 2 yet. Thank you. So we were able to schedule the family. However, they did end up no-showing the appointment, and then they were failed to be contacted by me again. So I actually turned to the primary care office to inform of the situation and ask for assistance getting them scheduled. The primary care office knew this family very well. They had 2 older children, and they never really had any issues before. However, more recently, they have been coming across them not coming to appointments. So they are actually a little bit concerned on their end as well. However, they had a better relationship, and I kind of left it in their court to be able to schedule them and get everything organized. The primary care office ensured us that they were doing the frequent feeding, and they talked with them extensively over the phone and when they came in for their well child visits about the importance of following up with this newborn screen. And we also brainstormed different options of getting them to Iowa City. Specifically, it did come out that the family didn't know that it was all the way in Iowa City, and they were kind of farther out, and they had no way of getting there. A couple resources that our state has is that through Medicaid, they can provide rides to Iowa City in different areas for health purposes. So we talked a little bit about the possibility of setting that up. Eventually, we actually got the infant scheduled in one of our outreach genetics clinics through our regional genetics consultation services. So a pre-existing program not necessarily designed for newborn screening, but where our metabolic geneticist was going for just a regular general genetics follow-up, and actually met with one of our general genetics genetic counselors apart from me as well. The family was also given scheduling freedom, as we may say, where we told them, just show up when you can and we'll be able to get you seen when you are available. the family was seen and the diagnostic testing was sent out. We did have some limitations with the outreach site being not at the University of Iowa, just with access to different resources, and that staff isn't as experienced as drawing on blood on infants as our staff at the main University of Iowa. And then also the PCP office was very responsive and checked in too to make sure that they were seen and to help us coordinate anything else that we did. Overall, no follow-up was required for this family, and the results were able to be communicated with the family and the PCP office as well. All right. And now I'm going to turn it to Jenny to talk about our next two examples.
Okay, so my experience in newborn screening has primarily been with the hemoglobinopathies and with cystic fibrosis. And so for the past 10 years working in the program, I've really had an interesting perspective on and kind of juxtaposing these two conditions or groups of conditions and comparing and contrasting them a lot. So example 2 is about hemoglobinopathies. Example 3, which we'll get to in a minute, is about cystic fibrosis. But in this example, historically, we did have hematology clinics that were specifically scheduled at the University of Iowa, where we could get newborn screening cases with new diagnoses connected with a team. It was a limited team, but it was a team kind of focused on working with families with hemoglobinopathies as a subset of hematology. And that went away when the faculty member moved on to a different institution. And for years then, we kind of drifted along with loss of the services that had been kind of carved out for this underserved population. So we lost the outreach clinics that we had done to some of the other cities, which, kind of balanced some of the loss of service or the lack of service in some of the other cities in the state, and eventually lost the standalone sickle cell clinics entirely. And so our sickle cell patients were just scheduled into random hematology clinics with any provider, and kind of lost that continuity and comprehensive care that had been established before. So after years of struggling with that, a new hematologist was recruited to the University of Iowa and was handed the reins to the newborn screening portion of the workload there, which in Iowa we have medical consultants for each of our specialties who are kind of assigned to the newborn screening program to be the kind of main point person for that condition or group of conditions. So this new physician was handed the reins to be the medical consultant for the hemoglobinopathies. Although she was an experienced hematologist, not new out of school or anything, her experience had really been with hemophilia. And so she had kind of a steep learning curve, but she did bring in quite a lot of energy and passion and bullheadedness at times, and was able to reestablish actually comprehensive sickle cell clinics for our population here. Some of the things the problems that we encountered and kind of followed through the years was that, as was referenced before, there's a lot of historical context for sickle cell disease that isn't always remembered, in that this is a condition that we've known about for a very long time, but still remain with just a single FDA-approved drug to treat it. There is a lack of organized funding sources or advocacy that we see in other populations. So like we have the CF Foundation that provides a lot of financial support for CF clinics and research. There's the MDA, which does the same thing for the muscular dystrophies. And while there are sickle cell disease and thalassemia support groups and advocacy groups, there is not a single entity nationwide. And so you get kind of a smattering of support and coverage, and it's just not as organized. I did also feel like I encountered a lot of institutional racism, and saw this forgotten disease lost in the shuffle of everything in the pediatric hematology oncology division. The patients themselves, as was mentioned before, are often perceived as being drug-seeking, difficult, non-compliant, and this all comes in a very sharp contrast to how the CF population of patients are seen. So when we brought in when the new hematologist was brought in and kind of bullied her way into saying this is something that we need to provide, she also was assisted in the fact that her predecessor had applied for and received funding through a HRSA sickle cell disease network program. And so our comprehensive sickle cell clinic is part of the Heartland Sickle Cell Disease Network group, and that funding allowed her to kind of get established and have a more robust comprehensive clinic. So we do have a physician, nurse practitioner, social work, psychology, dentistry, a researcher, and then myself as a genetic counselor to provide kind of comprehensive care. It did not start with a bang. It kind of started with a shrug and a lack of interest from a lot of people, but it has taken just a lot of dedication and time and work and care from the whole team to build bridges, to establish trust with some of the families, and just time and effort over and over again, multiple calls, following up on missed appointments to try to create a safe place and a welcome place for this population to come. So it is an interesting group. It's a lot of not Native Americans, but people who were born and raised here in the United States, as well as a significant proportion of new immigrants to the United States, either as refugees or through different immigration patterns. And so we're dealing with a lot of areas where we can face inequities, so language barriers, socioeconomic problems, and just differing levels of interest on the half of the patients and their families, as far as mistrust or distrust of the medical profession in general, and then from the groups, from some of the families that are coming from other countries, just a lack of understanding of this is something that can be treated, or this is something that you come in and get care even if you're not in a pain crisis. And so a lot of education going on, and a lot of struggle to keep the services as they are, kind of some pressure from the institution to as we all get everywhere, do more with less, and trying to cut back on things. But I think really the biggest solution here was a champion for this population in the physician that had been recruited, primarily again as a hemophilia expert, who then took this under her wing and has built quite a nice clinic. But I think having a champion for something, somebody who's willing to fight and point things out repeatedly that this is something that's needed was a big part of the success of this. The other piece of this that she has done is that we really have not had an organized advocacy or support group in this part of the country, or at least here in eastern Iowa, and we are now in the planning stages for our third annual Sickle Cell Symposium, which is a weekend event that is kind of put on and hosted by the staff of the sickle cell clinic, but it is directed towards families, community members, patients, and we tried to bring together not just the pediatric population, but the adult population as well, and provide education and working towards trying to get a little more organization and cooperation and coordination from the patients and families themselves, but that has been kind of difficult. We'd like to hand the reins over to this group of people, but again, they're dealing with, either themselves or their children have this, chronic disorder, and running something like that is hard. But I think that's been a big component of this, is being able to provide this education opportunity to bring these families together and to show and showcase in a more public forum what we're trying to do for the people in our community that have these conditions. So if we want to move to the third example now. So I think it's interesting too that, I just want to point out that working with two conditions that are primarily thought of as being prominent in one group versus anyone else is kind of interesting in a universally applied program like newborn screening, that it just kind of proves the equity that exists in newborn screening, that we screen all infants for sickle cell disease. We screen all infants for cystic fibrosis, even though we know the chance of finding sickle cell disease in somebody whose ancestry is, Irish is extremely low. We don't want to miss that, and part of that is just logistics. It would be almost impossible to kind of separate those out on the front end, but I think it just kind of supports that idea of this, equitable program in the public health sector that then has to shift over into the maybe not so equitable arena of medical care here in the United States. So in the third example, many of you are probably very familiar with the fact, or the history of the Hologic recall of their cystic fibrosis mutation screening panel back in 2016. And so early on, it was really struggling with the logistical problems of, this is kind of a right now situation that we need to fix, and we need to be able to continue screening. But out of that came a discussion of, okay, so what is available, and really being disappointed with, the options out there being primarily the baseline 23 mutation screening panel that really was originally designed to be a prenatal carrier screening panel for people with Caucasian ancestry. And it felt like a huge step back for several of us in our program to go from a mutation panel of 40 plus mutations back down to 23. And while that was necessary for the short term, we immediately started discussions of, we can use this for the time being, but where do we go from here? Because I think a large proportion of us felt like this was a blow to our program to have to cut back and go kind of step back. When we did actually review the cases of cystic fibrosis in the history of our newborn screening program, it became clear that we would not have missed any CF cases by using just a 23 mutation panel. We did have several examples or situations where the screening panel that we had been using detected both mutations, but one of them would not be on that 23 mutation panel. But those cases would still have been caught and sent on to do diagnostic sweat testing. But again, knowing that our population is kind of ever changing, and being predominantly a Northern European Caucasian ancestry population, it doesn't mean that we're always going to look the same way in the future. And so we realized that we needed to do something maybe different or better than what we had done before. And the other unique piece of this for us is that our state lab also does the screening for the states of North Dakota and South Dakota that have a specialty population or a unique population called the Hutterites. And we have known for a long time that there's a specific mutation in that population that we miss with the 23 mutation panel, with our historic panel. The M1101K mutation is, I think it's as common or maybe more common as Delta F508 in that specialty population. And we knew we had been missing this. We didn't have a way to add it to our previous panel, and it has always been kind of a thorn in our side and an issue. And so when we talked about and looked at the replacements that were available, it became clear that there wasn't anything out there that was going to cover that. And so we went a different route and decided to create a new screening panel for CF mutations based on our own screening populations. And so through cooperation with our CF clinics, we went through and did a systematic study of what mutations are present in our in our CF populations, and came back around to creating a screening panel that was going to be the most robust for our 3-state population. Now, we don't know what we're missing. We never do. We know also just realistically that you can't pick up everything. But, you know, knowing that we were able to fix the problem of a known mutation that we were missing in a select population, and being able to fix that for those families and for those providers, the CF providers in those states, felt really good. And then also to be able to kind of build back up to a more robust screen that may be more inclusive, even as our population changes over time, was really satisfying. And so, you know, it took a lot of time and cooperation and work, which isn't always easy. But again, I think it took even sometimes just a single person standing up and saying, this isn't fair. This isn't right. We are missing somebody, or we're potentially going to miss somebody with this screen if we do it the way we have been or that way. And I've not always historically thought of things under the title of equity. But when I was asked about, you know, this presentation today, I looked back and really thought, you know, a lot of the times when I'm most frustrated with the system, or most exacerbated, or, you know, just frustrated and angry because I can't get what I think is needed for people, looking at it through the lens of, you know, is this equitable or not, answers it, because we do need to give more support to those who need it more. You can't give the same to everyone and say it's equitable. You really have to do more for the populations that are struggling and don't have the same resources.
Okay, great. Thanks, Jaclyn and Jenny, for sharing your experiences. Really valuable to hear from your perspective. So now we're going to shift to questions. We also have Carol Johnson from Iowa Newborn Screening on the line to jump in on questions if need be. So thanks to her as well. So with that, if anyone would like to ask a question, you can send us one through the chat box, and we will read it off and get that answered for you. But to get us started, if there are any families listening in, if you'd like to share your perspective, we'd be glad to have that. If there are any state representatives here who have other health equity experiences they'd like to share, we think that'd be really valuable as well, or any other resources that we may have missed.
Yeah, we don't have any questions yet. Jenny or Jaclyn, if you, just to get us started, if you had any quick advice for other state programs on the line, since there seems to be a significant amount on the line. I know you went through many different examples. Could you tell us about like your top 3 advice? Or Carol.
is Jenny again. I think, having gone through this, I think my advice would really be to, we spend a lot of time looking at our programs and looking at timeliness and specificity and, the screening process itself, but taking a step back and saying, kind of looking at it and saying, are we serving our populations the best we can? Is there some way we can overcome problems with geography or distance from the state lab? Or, do we need to do more education in birthing centers or hospitals where they don't do as many screens, because that's where there's going to be, a higher poor quality rate or something like that. That just putting on those equity goggles and looking at all the steps in the process of the screening program to say, is there more that we should be doing for a group in our state or in our population, just because they're at a disadvantage, whatever that may be.
And then
Great.
also coming from the clinical side as well, in contrast, kind of where Jenny's looking at it more from the program's perspective, but kind of coming from the clinical perspective, thinking how can you use already established programs to kind of meet the needs of your patients, especially when you have more urgent instances such as newborn screens as well.
Great, thank you. Carol, if you're on the line, do you have anything to add?
Hi there. Good morning, everybody. Kind of echoing a little bit of what Jenny said, I think the other thing that is a challenge is meeting people where they are, so to speak. I had a great time yesterday doing a podcast with a local community library. And I thought to myself, why aren't we using libraries? That's where your public is, that's where your community is. And then my next thought is, thinking about this webinar that we were doing today, is where are these populations at that might be more liable to be subjected to health disparity? And how can we get our information about our program out there? So I think some of it is soul searching, right? And stepping back and thinking, how can we meet the needs of these special populations, if that's what we want to call them? And also being able to step out of your box. I think we all have our comfort zones, right? And I think it is important to step out of your box, because I think if you don't, first of all, you're going to just keep doing what you're doing, right? But more importantly here for this discussion, you might not ever reach those other populations where there are health disparities, where you really do want to communicate and touch base with them. So I think that's important too.
Great, thank you so much. I think you brought up a lot of important points. And I love that's something about the libraries is something that Baby's First Test is exploring. We've been working with some local libraries to explore what that means, and also trying to work with the American Library Association. From our partners, we have learned that a majority of the questions that are asked to librarians are health related. I think it's up to 70% was the last study, which is a lot. So if we can incorporate some of this information to libraries, I think that's great, since the majority of the public does go there. And I think about reaching the different populations, thinking about partnering. I think partnering is so key to making sure that we try to reach these different populations, and looking at different areas outside of newborn screening and perhaps health, libraries being one example of that. So I think that's really great. We do have one comment. It's more of a comment than a question, but it said after the last meeting, I believe this was the committee meeting, the advisory committee meeting, there was a vote for adding SMA to the RESP, and she was shocked to hear the dialogue about needing more than an incremental improvement in newborns. So that kind of speaks to the health equity piece, but also to the broader discussion of, what conditions get added to the RUSP. I'm not sure if anyone on the line or other people have a comment to that.
So this is, go ahead, Jackie.
Sorry, the same person has an additional comment, so I'm just going to add that, is that newborn screening is vital. As I stated earlier, it is likely that in infants in our healthcare system where there's the most equity, since there are many rare diseases with treatment that will impact infants and children, if they are not tested at birth, then we are at risk of testing infants and children with the devastating irreversible effects that have taken place. How can we tackle this? So that is from the same comment. One's a comment and one's more of a question. I'm not sure if anyone, one of the speakers, has any comments or to that question.
So this is Carol. I think the last comment is very profound, and I think that's in some ways how some of us in newborn screening are feeling about this. But I'm going to talk more specifically to the first comment. And one of the things that has concerned me about how quickly some of these new conditions have been added to the recommended panel is the fact that there's a lot of work to be done with conditions that we're already screening for. And there's a lot of work to be done with education and outreach. And there are limited resources in newborn screening programs. And how do you serve all those masters, essentially, right? So I hope maybe we have some breathing room after the addition of some of these new conditions, so that we can truly spend some time focusing on program improvement and education and outreach, particularly, to this, going back to our topic of discussion today, particularly to address some of the health disparities that do occur and work on those. That's a comment too. It's not really an answer to their comment, but just another comment. And I think many people feel the same way that I do about that.
Okay, so thanks, Carol, so much for answering that question. Food for thought. So we have another question that came through. That's how could someone assist as a mobile phlebotomist? And I think this brings up kind of the bigger point of how can we take maybe a sort of health systems approach and include other health professionals in tackling newborn screening health equity issues?
Does any one of the speakers have any thoughts on that? I think that's such an interesting question, and I think that's something that I think we haven't thought about, but I think there may be ways.
So this is Carol. Yeah, that's a novel thought and something I hadn't thought of either. And maybe it also kind of along those same lines. I know Arizona has tied in their newborn screening program with their Visiting Nurse Association. So that, that's a great idea.
Yeah, and there may be a way to combine education too.
Right, exactly. Yeah.
Community. So that is something we'll definitely keep in mind for our program, but also something for, state programs to consider. So thank you for asking that question.
Yeah, it's really a great idea. Like mobile health clinics are such a useful resource, especially in areas where there's little geographic access to different metabolic clinics or any healthcare services, really. So that's an interesting idea for how we could do education and outreach and maybe see different ways that those resources could be used to address health equity too.
Great. Well, we don't have any more questions coming in, and I know that we're at the top of the hour. So, of course, if there's any more questions, you can contact Babies First Test staff, either Jackie at babiesfirsttest.org or Annie at babiesfirsttest.org. You can also learn more by going to our site, babiesfirsttest.org, and spanish.babiesfirsttest.org. We do want to thank our panelists for joining today. And as a reminder, we do have one more webinar next Monday about engaging Spanish-speaking families. We will have the link on our social media as well as in our newsletter. If anyone else needs a link, we're happy to send it to you. And I think that's it.
So just one last time, thank you everybody for joining us, particularly to our panelists. So thanks so much, and we hope you all have found this useful.
Great, and we will have the webinar recording up on our YouTube channel within 48 hours. So thank you, everyone.
Thank you.